So today we will discuss regarding the management of hemorrhagic stroke. So first of all, a brief introduction regarding the stroke. So what you mean by stroke? So another name of the stroke is cerebrovascular accident, or commonly known as a CVA. So what is stroke? So stroke or cerebrovascular accident is defined as abrupt onset of neurologic deficit which is attributable to a focal vascular cause. So this is the definition of the stroke, which is also known as the CVA or the cerebrovascular accident. So there are the three terms. Terms which are important in this stroke. First, there should be abrupt onset, means that should be a sudden onset and leading to a neurological deficit. So there must be some neurological deficit. So this neurological deficit may be in any form. It may be a sensory loss, it may be a motor loss, or it may be loss of consciousness, or loss of speech, or loss of anything. So there must be a neurological deficit, and which is due to a focal vascular cause. So there should be a sudden onset leading to a neurological deficit, and which is due to a vascular cause. So this is known as the stroke or the cerebrovascular accident. So this definition of the stroke is clinical. So by the clinical examination of the patient, we can come to the conclusion whether the patient is suffering from stroke or not. But only the labeling of stroke is not sufficient. Now we have to move further. We have to categorize this stroke whether it is a ischemic stroke or a hemorrhagic stroke. So what you mean by ischemic stroke, or also known as the non-hemorrhagic stroke, when the blood vessel occludes. So whenever a blood vessel in the brain occludes, it will lead to a ischemic stroke or the non-hemorrhagic stroke. And when this blood vessel ruptures, it is known as a hemorrhagic stroke. And why this characterization is important? Because the treatment of both the ischemic stroke and the hemorrhagic stroke is different. So in today's class, we will discuss regarding the management of hemorrhagic stroke. In another class, we will discuss regarding the management of ischemic stroke or the non-hemorrhagic stroke. So we have made a clinical diagnosis of the stroke and the laboratory studies, including the brain imaging. This brain imaging can be done through the CT scan or through the MRI, and it is used to support our diagnosis whether the patient is having a stroke or not, and what is the type of stroke, whether it is a ischemic stroke or the hemorrhagic stroke. So this is the definition and the classification of the stroke. So now we come to our main topic, that is the management of hemorrhagic stroke. So when the hemorrhagic stroke occurs, so the hemorrhagic stroke occurs when a blood vessel in the brain ruptures and bleeds. So any blood vessel in the brain, whether it is the anterior cerebral artery, middle cerebral artery, or the posterior cerebral artery. As you all aware that there are three important, these are the branches of the arch of aorta, and these are the anterior cerebral artery, middle cerebral artery, and the posterior cerebral artery, which are forming the circle of Willis. Whenever any artery ruptures, there is a bleeding into the brain parenchyma, which leads to the hemorrhagic stroke. So the blood vessel ruptures in a hemorrhagic stroke, whether it is blocked in the ischemic stroke. So this is the basic difference between the ischemic stroke and the hemorrhagic stroke. Now the hemorrhagic stroke can be of different types. It can be intracerebral hemorrhage, also known as the intraparenchymal hemorrhage. Whenever there is a bleeding within the brain parenchyma, it is known as the intracerebral or the intraparenchymal hemorrhage. There may be AV malformations. There may be arteriovenous anomalies are there in the brain. There are different 8 arteriovenous anomalies are there, or the malformations are there, and due to the bleeding from these AV malformations or the AV anomalies, there is a hemorrhagic stroke. Then there is a subarachnoid hemorrhage whenever the bleeding occurs in the subarachnoid space. As you all are aware that our brain is covered by the three matters, that is the dura mater, arachnoid matter, and pia mater. And the space between the pia mater and the subarachnoid and the arachnoid matter is known as the subarachnoid space. And when this bleeding occurs in the subarachnoid space, it is known as the subarachnoid hemorrhage. And there, apart from these, there may be other causes when the bleeding occurs in the subdural space or the epidural space. So it can be of intracerebral hemorrhage, arteriovenous malformations, subarachnoid hemorrhage, and others where the bleeding occurs either in the subdural space or the epidural space. So these are the different types of the hemorrhagic stroke which we will discuss one by one. So first is the intracerebral hemorrhage or the intraparenchymal hemorrhage. So this ICH, that is the intracerebral hemorrhage, it is the second most common cause which accounts for 10% of all the strokes, and 35 to 45% of the patients die within the first month. By this you can come to a conclusion how serious it is, because in the majority of the patients who are suffering from the ICH dies within the first month. That's why the important is the diagnosis and the early treatment. If the diagnosis is delayed, if the treatment is delayed, if the diagnosis is not proper or the treatment is not proper, majority of these patients die within the first month. And a rate which is approximately 5 times greater than the ischemic stroke. So the prognosis or the mortality is much more higher in the hemorrhagic stroke in comparison to the ischemic stroke. And there are the different etiologies which can lead to the intracerebral hemorrhage, and the most common one is the hypertension. Then coagulopathies, use of sympathomimetic drugs like cocaine and methamphetamine, and cerebral amyloid angiopathy. So these are the different causes which can lead to the intracerebral hemorrhage or the intraparenchymal hemorrhage. If we talk about the risk factor, there are different risk factors like the alcohol use, smoking, advanced age, and the use of low dose aspirin. So these are the risk factors which can lead to a patient to a intracerebral hemorrhage. And the etiologies may be differ in the elderly patients and may be differ in the younger patients. If we talk about younger patients, the two most important cause of intracerebral hemorrhage is the use of cocaine or the methamphetamine, which are the sympathomimetic drugs which can lead to the ICH in the young patients. And how will you make a diagnosis of ICH? That is through the brain imaging. And in the brain imaging, there are two most important brain imaging are the CT scan and second is the MRI. But the most commonly used is the CT scan, and we have to go for non-contrast CT scan. Why we are going for non-contrast CT scan? Whenever a patient comes to you with this stroke, we do not know the renal status of the patient, and if the renal status is not known to you, it is better to go for non-contrast CT scan, because if the person's renal status is not perfect and we are giving the contrast, it can lead to contrast-induced nephrotoxicity. That's why any patient comes to you emergency with the diagnosis of stroke, first of all you should go for a non-contrast CT scan. And why we are not going for MRI? Because the availability and feasibility of the non-contrast CT scan is much better than the MRI. It is a cheap, easily available and feasible to read the CT scan. That's why we have to go for non-contrast CT scan rather than the MRI. If your CT scan is normal, that means the patient is not suffering from the hemorrhagic stroke. Then your diagnosis is clear. Then the patient is suffering from ischemic stroke. Then to categorize this ischemic stroke, you may require a further investigation in the form of MRI. 99% cases, if the patient is suffering from hemorrhagic stroke, your diagnosis will be clear by the non-contrast CT scan. And as all patients, you should first go for a emergency management of these patients. And our emergency management resolves around the A, B, C, that is airway, B is the breathing, and C for circulation. So first of all, we have to carefully watch for and carefully monitor the patient's ABC, that is airway, breathing and circulation. So the close attention should be paid to the airway management, because a reduction in the level of consciousness is common and often progressive, because these patients are usually having altered sensorium. That's why the management of airway is very important. And usually in this patient, it has been seen that the patients are suffering from hypertension, which is usually accelerated or the essential hypertension. So with the use of appropriate drug, that is the non-vasodilating IV drugs such as nicardipine, labetalol or esmolol, we should try to we should make normotensive these patients. So we should carefully reduce these blood pressure of these patients, otherwise the high blood pressure will lead to the further bleeding, chances of bleeding. So that's why the careful management of the blood pressure is very important. And in comatose patients, we have to monitor for the intracranial pressure, because these patients are having the increased intracranial pressure, that is raised ICP. And how this raised ICP can be monitored? It can be monitored through the tracheal intubation and sedation, because if we doing the tracheal intubation and sedation, we are using the reduction of the ICH, reduction of the ICP in these patients. We should go for administration of diuretics. So diuretics can be done through the use of mannitol, through the use of diuretics like the furosemide or the hypertonic saline, and elevation of the head and of the bed. So these all maneuvers can reduce the ICP of the patient, because in the patients of intracerebral hemorrhage, it has been seen that the patients are suffering from raised ICP, and this raised ICP, apart from the raised ICP, these patients are having the hypertension and the bradycardia. So the management of the raised ICP and hypertension is very important in these patients. After managing the initial condition of the patient, monitoring the ABC of the patient, now we have to go for further workup. So we have to go for laboratory studies. These are the routine blood chemistries like the CBC, renal function test, liver function test, ECG, chest X-ray, and sugar monitoring. Apart from these investigations, to rule out coagulopathy, we have to go for different tests like the platelet, look for the prothrombin time, activated partial thromboplastin time, and the PT-INR. So to rule out coagulopathy, we require the PT, APTT, or PT-INR. If the patient's the PT, APTT, or the PT-INR is abnormal, we have to correct this coagulopathy. If we do not correct the coagulopathy, the persons will have the more chances of bleeding. And after doing the routine blood chemistry and specific blood chemistry, we have to go for a CT stain, which detects the hemorrhages in the supratentorial space, but there are certain chances that the posterior fossa lesions or the brainstem lesions might not be picked up by the CT stain. In that cases, we may require the MRI, because MRI is much more sensitive than the CT stain to detect the posterior fossa lesions or to detect the lesions in the brainstem, that is the pons, midbrain, and medulla. If we are suspecting lesion in the brainstem, so first of all we go for CT stain, and the CT stain is normal and your diagnosis is hemorrhagic stroke, then we go for a MRI stain. And we can go for further workup in the form of MR angiography or the CT angiography when the cause of intracranial hemorrhage is uncertain, particularly if the patient is young or not hypertensive and the hematoma is not in one of the usual site of hypertensive hemorrhage. Because if after doing the CT stain and MRI we cannot come to the conclusion what is the cause of intracerebral hemorrhage, then we have to look for the arterial tree, which can be done through the CT angiography or the MR angiography, because there is a possibility that these persons might be suffering from arteriovenous malformations or the aneurysms, which rupture of which is leading to the intracerebral hemorrhage. And the treatment, after immediate attention to the blood pressure and airway protection, the focus can be shifted to the medical management and the surgical management. And what is the medical management? If the person is taking the vitamin K antagonist, the rapid correction of coagulopathy can be achieved by the use of PCC, that is prothrombin complex concentrates, which can be administered quickly with the vitamin K administered concurrently. So if the patient is on oral anticoagulants, so this use of oral anticoagulants leads to the coagulopathy, which can be corrected through the use of vitamin K and the PCC. Why we are not using the FFP? Because the infusion of the FFP requires a large volume and the correction usually occurs slowly. That's why we are using the injection vitamin K and the prothrombin complex concentrates rather than the FFP for the medical management. And what is the surgical management? If The surgical management depends upon the condition of the patient. Suppose the patient condition is stable and on the monitor, and you are doing the follow up of this patient and the condition is remains stable or improving but not deteriorating, then we can continue with the medical management. But if the condition of the patient is deteriorating and the person is not responding with the medical management, then we have to go for surgical management. So it all depends upon the condition of the patient. And one important thing regarding the cerebellar hemorrhage. You all know that there is cerebellum which has having two cerebellar hemispheres which are joined together the vermis, and this cerebellum lies in a closed space because there is a limited space available for the expansion. Suppose the patient is having bleeding in the frontal lobe, parietal lobe, occipital lobe, or the temporal frontal lobe, parietal lobe, or the temporal lobe. There is a space for the expansion, but the cerebellum lies in a closed space, so there is not a space for expansion. So cerebellar hemorrhage is much more serious rather than the bleeding occurring in the rest of the lobes. So the treatment depends upon the size of cerebellar hemorrhage. If the size of cerebellar hemorrhage is more than 3 cm, you should go for a surgical management. And if the size of the cerebellar hemorrhage is less than 1 cm, you should go for a medical management. And when the size of cerebellar hemorrhage is between 1 to 3 cm, your treatment depends upon the condition of the patient. If the condition is stable, go for medical management, and if the condition is not stable, go for the surgical management. So in the case of cerebellar hemorrhage or the cerebellar hematoma, the treatment depends upon the size of the hematoma. And in the prevention part, as you all know, the hypertension is the leading cause of primary ICH. So your prevention part is aimed at reducing the blood pressure of the patient, which can be done through the lifestyle measures. We should advise the patient to restrict the sodium intake. We should encourage the patient to do exercises. We should encourage the patient to do a morning walk and evening walk. So all the lifestyle measures can lead to the reduction of the blood pressure, and this reduction of the blood pressure will lead to the reduction in the incidences of the ICH, because hypertension is the leading cause of ICH. So now next part is the vascular anomalies or the AV malformations. So the vascular anomalies, they can be divided into two types. They can be congenital or they can be acquired. So they can be congenital vascular malformations or they can be acquired vascular malformations. And these congenital vascular malformations are usually silent. They usually remain silent throughout the life, and they are usually located in the posterior part of the hemisphere. So this is the congenital vascular malformations. Usually you will get that it is an incidental finding. You are doing the MRI for the another cause, and you are getting the AV malformations or the vascular anomalies. So if it shows that these are the congenital, because congenital vascular malformations are usually silent and are located in the posterior part of the hemisphere. These congenital vascular malformations may be part of familial AV malformations like the Osler-Van de Wever syndrome. So this is the syndrome where you can get the familial arteriovenous malformations. And what are the different signs and symptoms? These vascular anomalies may present in different ways. The patient may complain of headache, seizures, or the patient may develop the intracerebral hemorrhage. If there are large arteriovenous malformations of the anterior circulation, the patient may have a bounding carotid pulse or a systolic and diastolic bruit over the eye. So these are the different signs and symptoms which can be seen in arteriovenous malformations. So these are the different pictures of the CT stain, MRI and MR angiography which are showing the arteriovenous malformations which are leading to the hemorrhage. So these are the AV malformations which are leading to the hemorrhage. So this is the hemorrhage. So these are the hemorrhages through the AV malformations. And what is the management of these malformations? So first, the diagnosis. So diagnosis is done through brain imaging, and in comparison, and if we compare the MRI with the CT stains, the MRI is usually better than CT stain for the diagnosis of AV malformations. Once you are identified the AV malformation through the CT stain or MRI, we should go for further workup in the form of MR angiography or the CT angiography. And after the confirming the diagnosis that the patient is suffering from AV malformation, then we have to go for a definitive management. In the definitive management, first is the surgery, and there is an alternative to surgery is the stereotactic radiosurgery. So the definitive management of AV malformations are the surgery. But is there any role of surgery in asymptomatic AVM? That is uncertain. So one school of thought is that these asymptomatic AVM should be operated, but another school of thought says that these AVM should not be done through the surgery. They should only be got a follow-up. If the size of these AVMs are increasing with the passage of time, and if the patient becomes symptomatic in the future, then only the surgery should be done. So the role of surgery in asymptomatic AVM is uncertain. Next is the subarachnoid hemorrhage, that is the bleeding into the subarachnoid space, which is lying between the dura mater, which is lying between the pia mater and the arachnoid mater. So what is the cause of subarachnoid hemorrhage? So the most common cause is the head trauma. So any trauma to the brain head can lead to the subarachnoid hemorrhage, and the second most common cause is the rupture of saccular aneurysm. So these are the two most common etiologies of the subarachnoid hemorrhage: head trauma and the rupture of saccular aneurysm. Other causes may be bleeding from a vascular malformation and extension into the subarachnoid space from a primary intracerebral hemorrhage. So patient is suffering from the intracerebral hemorrhage, and there is extension of the intracerebral hemorrhage into the subarachnoid space, which is leading to the subarachnoid hemorrhage. So these are the different causes of subarachnoid hemorrhage. Now few words regarding the saccular aneurysm. So what are the aneurysms? The saccular aneurysms are the abnormal focal dilatations of the cerebral arteries with thinning and weakness of the vessel wall. So due to the development of this aneurysm, the vessel wall becomes thin and weak. So whenever the pressure is put on these aneurysms, there may be possibility of rupture, which is leading to the subarachnoid hemorrhage. And the annual risk of the rupture for the aneurysm less than 10 mm in size is 0.1%, and for the aneurysm more than 10 mm in size is 0.5 to 1%. So this is difference in the risk of rupture according to the size. If the size is small, the risk of rupture is less. If the size is more, the risk of rupture is more. And the most important locations for these aneurysms are the terminal internal carotid artery, middle cerebral artery bifurcation, and the top of the basilar artery. So these are the commonest locations of the saccular aneurysms. And there is a grading of the clinical manifestations of subarachnoid hemorrhage, and there are different scales have been given to characterize these patients of subarachnoid hemorrhage, and the most commonly used is the Hunt-Hess scale, where the subarachnoid hemorrhage has been graded from 1 to 5. And in the imaging, first of all, you should go for a CT stain, and majority of the cases of subarachnoid hemorrhage can be visualized on the CT stain. But if the CT stain is not able to make a diagnosis, a lumbar puncture can be done. And after the characterization of the subarachnoid hemorrhage, you should go for a angiography, which can be a MR angiography or the CT angiography, which can give you a diagnosis whether the patient is suffering from saccular aneurysm or not. And in the laboratory evaluation, you should go for a lumbar puncture, but the lumbar puncture should be done only when you have ruled out the when you have done the CT stain, and when you do a fundus examination and the fundus examination is normal. Suppose the patient is having a on the CT stain the person is having a cerebral edema, and in the fundus examination the patient is having a papilledema, and if you done a lumbar puncture, it can lead to a cerebellar herniation and the immediate death of the patient. That's why the CT stain or the fundus examination should be done prior to doing the lumbar puncture. But if the facilities of the CT stain and the fundus examination is not available, and you have to do the lumbar puncture, it is safe to do a guarded lumbar puncture where the stellate is not removed from the lumbar puncture needle. And electrolytes should be measured in these patients frequently because these patients are prone to hyponatremia, and this hyponatremia can make the prognosis of the subarachnoid hemorrhage worse. That's why the periodic monitoring of the electrolytes, particularly the sodium, is very important. Then ECG. In these patients, the ECG may show different changes. There may be a QT prolongation, there may be ST changes and T wave changes. So it is very difficult whether these patients are having concomitant myocardial ischemia or myocardial infarction is having or not. So in this scenario, we can do a cardiac enzymes. Suppose the patient ECG are showing different changes and you are not able to come to the conclusion whether the patient is having concomitant cardiac problem or not, then in this patient you should go for cardiac enzymes. If the cardiac enzymes is normal, that means these changes are due to subarachnoid hemorrhage rather than due primary cardiac problem. But if the patient's cardiac enzymes are positive, that means these changes are due to a cardiac problem. And the management of this cardiac problem is very important apart from the management of subarachnoid hemorrhage. So what is the treatment? The treatment regime involves early aneurysm repair to prevent the re-rupture. So the aneurysm repair is very important because otherwise the patient may have a further rupture and further bleeding into the brain parenchyma. And protection of the airway, management of the blood pressure before and after the aneurysm treatment, and managing the intracranial hypertension, delayed cerebral ischemia and hyponatremia, and to prevent the pulmonary embolism. So these are the categories of our treatment of subarachnoid hemorrhage. And how the aneurysm repair can be done? The aneurysm repair can be done through clipping, coiling, or through newer techniques. The clipping is usually done through a neurosurgeon, the coiling can be done through an endovascular surgeon, and there are newer techniques which can be done for the repair of aneurysm. And how will you manage the intracranial hypertension? The intracranial hypertension can be treated through the use of diuretics, through the use of hypertonic saline, through the use of mannitol. So all these maneuvers can reduce the intracranial hypertension. And the diffuse cerebral ischemia, it is the leading cause of mortality and morbidity following the aneurysmal subarachnoid hemorrhage. So the management of diffuse cerebral ischemia is very important, and it is usually achieved with the use of nimodipine, and this nimodipine is a calcium channel blocker, and the dose of nimodipine is 60 mg every 4 hourly, which improves the diffuse cerebral ischemia and reducing the mortality and morbidity of these patients. But despite the optimal medical therapy, the diffuse cerebral ischemia persists, then in these cases we can go for intra-arterial vasodilators and percutaneous transluminal angioplasty. So first treatment is the use of nimodipine. If the person is not responding with the nimodipine, we can go for angioplasty or the use of vasodilators, which are the treatment modalities for diffuse cerebral ischemia. Now come to the management of hyponatremia. And many of these patients continue to experience a decline in serum sodium despite receiving the parenteral fluids containing normal saline. So in these patients, we have to manage the hyponatremia, and we have got different maneuvers to treat the hyponatremia. So first is the use of normal saline. If the person is not responding, we can go for a hypertonic saline, that is the 3% saline. In the normal saline, that is known as the NS, the quantity, the sodium is 0.9%, and there is a half NS in which the sodium is 0.45%, and there is a hypertonic saline in which sodium is 3%. So if the person is not responding with the normal saline, we can go for a hypertonic saline. Suppose the person's sodium is less than 120, in that cases we have to go for use of hypertonic saline. But this use of hypertonic saline should be used very carefully, because if we go for rapid correction of the sodium, the patient may develop the osmotic demyelination syndrome. So it is a dictum that in a day not more than 6 to 8 milliequivalent correction of sodium should be done. Suppose the patient is having a sodium of 110. So with the use of appropriate measures, with whether it is the hypertonic saline, whether it is through the normal saline, or with the use of increased salt intake in the diet, the correction should not be more than 6 to 8 milliequivalent in a day. So if the person is having a sodium of 110, we should make it only up to 116 or 118 in a day. We should not go for a rapid correction of sodium, because if we correct the rapid correction of sodium, the person may develop the osmotic demyelination syndrome. And this osmotic if the person develops this osmotic demyelination syndrome, it is a irreversible stage. We do not have any treatment modalities to correct this osmotic demyelination syndrome once it occurs due to the rapid correction of sodium. That's why the correction of this hyponatremia is very important, and it should be done very carefully. And now the last part, that is the hydrocephalus, that is the ventricular dilatation, that is the fluid accumulation in the ventricles. And the treatment differs upon differs whether the hydrocephalus develops acutely or chronically. If the person is having the acute hydrocephalus, it may require the ventricular drainage. If the person is suffering from chronic hydrocephalus, then ventricular shunting is the treatment of choice. So the treatment differs whether it is a acute hydrocephalus or whether it is a chronic hydrocephalus. And apart from the management, the DVT prophylaxis and treatment is very important, because these are the patients which are usually bed bound. And because these are the bed bound patients, so development of deep venous thrombosis is very common in these patients, because these patients are bedridden, they are not moving their lats. That's why the development of thrombosis in the veins of the lats is very important, and this development of DVT can lead to the chances of development of pulmonary embolism. So the prophylaxis and the treatment of DVT in these patients is very important. So in these patients, first of all, the pneumatic compression stockings application should be done, because the application of the pneumatic compression stockings prevents the development of DVT, which prevents the development of pulmonary embolism. If suppose the patient, despite of all your preventive measures, the person develops the DVT, then it should be corrected with the use of unfractionated heparin. It can be initiated within 1 or 2 days following endovascular treatment or craniotomy with surgical clipping, and it is a useful adjunct to pneumatic compression stockings. But it is contraindicated in patients with ruptured and untreated aneurysm, and it is a relative contraindication following craniotomy for several days, and it may delay the thrombosis of a coiled aneurysm. If we are using the unfractionated heparin, we should give it for a short duration of time, for 5 to 7 days. Then after the use of heparin, we have to continue with the vitamin K antagonist. So this vitamin K antagonist can be the conventional or can be newer one. In the conventional, we are using the acinocomerol, we are using the warfarin. In the newer ones, we are using different rivaroxaban, we are using dabigatran, or we are using the apixaban. And if DVT or pulmonary embolism occurs within first days following craniotomy, the use of inferior vena cava filter may be considered to prevent additional pulmonary embolism, whereas systemic anticoagulation with heparin is preferred following successful endovascular treatment. So the DVT prophylaxis and treatment is very important in these patients. If the person develops the pulmonary embolism, the chances of survival becomes less in these patients.